If I were to save your time and sum this whole video up, it would be screaming pregnant women, cute babies, and lots of vaginas. Hello everyone, my name is Joanny and welcome to Love Qualified. I am a second year physician associate student training in London, and today I'm going to be telling you guys all about my obstetrics and gynecology placement. So I've just finished my 3 weeks and I thought that I would come on here and just tell you guys a little bit about my experience and what I learned as well, and just some tips for those of you who are going to be starting your obstetrics and gynecology placement in the future. I have also done a similar video for my geriatric medicine placement, which I'm going to link below, so go and check that out if you are interested. I started off my first day on obs and gynae 3 weeks ago in the same hospital as I did my geriatric medicine placement, so I didn't have to go for the induction, so I skipped the induction that morning. I decided not to drive to placement anymore because for the first 3 weeks I was driving to placement, and it was really expensive to drive, and so I decided to just bus it really, and I've been very happy since I've been taking the bus, so that's fine. Anyway, on the first day of my placement, the bus was delayed, so I ended up getting there I think almost 10 o'clock. I didn't have a timetable yet for the day, but then I was taken to the clinic. So obs and gynae has loads of different aspects to it, so I'm just going to tell you guys about all the different aspects to obs and gynae and my experience with it. So on the first day I sat in the clinics with the consultant. So it was a gynecology clinic, and they were seeing patients who had been referred to the clinic either by the GP or if it was a follow-up session, or they'd been referred by someone else. And a lot of the patients who coming in there had presenting complaints such as irregular bleeding, so a lower abdominal pain, left iliac fossa pain or right iliac fossa pain, and also abnormal vaginal discharge as well. So the consultant would take a full history and then come up with differentials, and they would examine the patient if they need to, and then they either send the patient off with a plan, so maybe medications, or they organize more investigations like hysteroscopies, which is when they look inside when they have to use a camera to look inside the womb, or laparoscopies where they use that to look inside the abdomen. Conditions such as fibroids, endometriosis, ovarian cysts, or just loads of other conditions to do with the ovaries and female health as well. So that was good. And then when I finished that clinic in the morning, I had the antenatal clinic in the afternoon, which I was with the same consultant, but then she was seeing pregnant women, so pregnant women who were just coming in for their appointments. So usually pregnant women who have low risk pregnancies, so low risk as in they don't have any other problems during pregnancy, they would just be looked after by their midwife. But then if they have other problems, say maybe they have diabetes during the pregnancy, which is called gestational diabetes, or if they have high blood pressure during the pregnancy, if they're carrying twins, or if there's some other problem or some other thing that they have to monitor during the pregnancy, they will usually be seen by the consultant as well. And the consultant can then look at they have additional scans, look at their scan results, and then organize more scans or organize follow-up appointments and stuff like that, or give the medication if there's supposed to be a medication, for example, to control their high blood pressure, or a medication to try and prevent them from having a miscarriage, for example, if they've had miscarriages in the past, or if they have a history of premature births and stuff. So these women are also seen by the consultant as well, so that they can manage them properly. So these are termed high risk pregnancies. Those were the kind of patients that we were seeing in the antenatal clinic. They also listened to the baby's heartbeat, checked that the heart rate was fine, and then they did an antenatal exam just to check for the position of the baby. On that very first day, I went for a teaching session with some of the medical students, and it was all about antenatal screening. Now mind you, before I went for that teaching session, I wasn't expecting this consultant to make us answer questions. So because there were only 4 of us, it was myself, another PA student, and then 2 medical students, 2 4th-year medical students. You know, the medical students, because they had read up, that was like their 5th week on the placement. This was my first day on the placement, so I knew nothing, and I hadn't prepped as much before that placement, which was a terrible thing, because I advise you to always prep really well before you start a placement, because it always helps. So I went in for that teaching session. My other PA colleague, she had worked in maternity and she's a mother as well, so she knows quite a few things about obs and gynae. I was just there like, I mean, I did answer some questions, but I needed to revise, because a lot of the things she was asking, we had gone over these things and they had taught us last year, but because I hadn't gone over my notes, I had forgotten them. That actually made me feel a little bit low, because when I left that day, I was like, oh my gosh, like all these people know these things, I don't know this. But then that, I sort of used that as a stepping stone, because it motivated me to be more serious about revising and also making sure that my after placement study routine was in place. This is the book that I have been reading. I know that it says Oxford Handbook of General Practice, but trust me, this book goes through like all the different systems, including obs and gynae, and it goes through all the basic things that you need to know for the obs and gynae placement. Honestly, as from a generalist point of view, looking at obstetrics and gynecology, which PAs are technically, unless you're going to be a PA working exactly in obs and gynae, then you're going to have to know about their specific guidelines. But from a generalist point of view, if you want to know more about, you know, the basic things that you need to know about the obs and gynae specialty, this book has everything. Because as I was reading this on the bus in preparation for my placement, everything that they mentioned during my placement, you know, is in this book, and it really helped me to prepare after the first day when I just felt so lost. This book really helped me, so I would recommend that. On the second day in the morning, I was sat in with a nurse specialist in the fertility clinic. She was so lovely. So she saw women who were trying to get pregnant. Sometimes the women came with their partners, but sometimes they came on their own. And what she would do is she would just take a history from them, trying to gauge what the problem is, and then she would send them off for more investigations, just to get just to get the ball rolling. She asked a lot about their past medical history, about family history, asked if they are in a consanguineous relationship, because that has significant effects as well if that is the case, as well if they've ever had children before with other partners or together. For the last patient that we saw that morning, she actually let me ask the questions. It was a sheet and I had the template and had all the different questions there, and she let me ask the questions, which was really nice. It wasn't as easy as it sounds, because then you think, yeah, you're just reading off the questions. No, because you had to ask the questions in such a way that you excluded medical jargon. It's just a way of phrasing the question in a way that the patient would be able to answer. So I thought that was good. And then in the afternoon that day, I went and sat in with the sonographer, and the sonographer was doing the 20-week anomaly scans, or high resolution anomaly scans. So in low risk pregnancies, women usually have 2 scans. They have the early scan, which is about, I think, 11 to 13 weeks, and then you have the high resolution anomaly scan, which is about 18 to 20 weeks. And when they come for that scan, the couples usually would find out the sex of the baby. If the sonographer can see in between their legs, they find the sex of the baby. Some people didn't want to know the sex of the baby, which was fine. And then the sonographer would look for the different try and look at the anatomy of the baby, look at their face, check that they have 2 eyes, they have 1 nose, they have lips, check that they have a stomach, because then you would see fluid in the stomach, which will appear as black on the scan, just to make sure the baby's swallowing properly. Check the bladder, which will appear as black as well. So if there's urine in the bladder, it would appear as black, which would mean that the baby's kidneys are working properly. They would check the baby's legs, check that try and make sure that they see the feet and the toes and all of that, and check the baby's spine and check the baby's head, and they would do measurements around. And yeah, it was really cool. And to see these couples come in, and then they'll see their baby. Also check the position of the placenta as well, because it's very important to know where the placenta is, because there's some conditions which involve the placenta, like placenta previa, where the placenta is in the lower segment of the uterus and it is an increased risk of bleeding later in the pregnancy. And they did some measurements as well, just to make sure that the baby is growing well. Some women, if they couldn't see certain features of the baby, they would ask them to book another scan and they would come back. And then for some women, if the baby was maybe smaller than normal, small for their gestation or too big for their gestational age, they would organize another scan and ask them to come back so they can recheck. And sometimes they would refer these ladies to the consultant, and the consultant would do the scan themselves as well. And then on the Wednesday, I went to the labor ward. So the labor ward is where the women who are in active labor, that's the ones that they are brought to the labor ward. And labor is very unpredictable. It's not something that, you know, takes, I mean, it could take about an hour, but it could take like up to 24 hours or so for you, from when a woman's water breaks to when she actually gets this baby, so to when she actually delivers her baby. The very first day we saw an elective cesarean section, my other PA partner and I, and it was really it was a shock, because you don't realize that a cesarean section is actually major abdominal surgery. Like, we stood there, they gave us like the hair nets. I had to take like 2 hair nets to get this hair underneath, and because we didn't have Crocs, we were wearing our own shoes, so we had to use some plastic things to like cover our shoes before we went into theatre. We didn't scrub in because we weren't doing an operation. But later on, I think they actually let one of my colleagues, my PA colleagues, assist with the C-section, so which is really good. And we watched, and the theatre staff were really nice. They explained to us what happened, how they would talk to the lady who was coming in, ask her questions just to make sure that she knows what she's going in for. And then when she would go in, the anesthetist would do the spinal anesthesia and make sure that she can't feel anything down from her waist downwards. And then the person who is performing the cesarean section, the consultant, will come in and do they would position her obviously, and then he'll come in and do the cesarean. Someone usually assists the person carrying out the surgery. They would do the incision, open it up, and then, you know, take the baby out and then suture it. I mean, it's not as easy as I'm making it sound, but, you know, technically, in a whole nutshell, that's what it is. And the midwife would be there. If it's a low risk pregnancy, if there's nothing to worry about, the midwife would be there to look after the baby and then bring the baby to the mom. But then if they're worried about the baby, the well-being of the baby, then they will usually involve the pediatric team, so that when they get the baby out, the pediatric team will take over and try to make sure that the baby's okay. And then on the Thursday in the morning, I was in the gynecology ward. So there's a ward that's dedicated for gynecology patients. A lot of them have had surgeries that had gynecology conditions, say fibroids, if they've had myomectomies for fibroids, so when they've taken out the fibroids, or if they've had surgery to remove ovarian cysts, or some patients who had other conditions like ovarian cancer. Yeah, loads of other gynecological conditions. They were admitted on this ward and looked after, and then they had this surgery. I was there with the foundation doctors. They were really good. We went on the ward round, and I came back and I helped out with some jobs. But then I also went in to the colposcopy clinic. So I was with the colposcopy nurse specialist. In the colposcopy clinic, colposcopy is basically quite similar to a speculum exam, but then the nurse uses a microscope and she blows up the image so she can have a proper look at the cervix, and just to make sure that there's nothing abnormal going on there. So for example, women who have irregular bleeding, they can be referred for colposcopy just to have a look in the cervix, just to make sure that there's no things like polyps or ectropions or any ulcers or things like that, things that would cause the bleeding. Also, women who have abnormal results on their smear test, so when they do the smear test to check for cervical cancer, sometimes it can show some abnormal results, so they can also be referred to for colposcopy. Yeah, that was my experience at the colposcopy clinic. On the Friday, on the Friday of the first week, I actually helped deliver twins. So the twins were only 30 weeks old, which is slightly earlier. Normally term is above 37 weeks, so from 37 to 40-ish, but twins usually come early anyway, but this was particularly early because the woman's waters hadn't even broken. So they had to involve the pediatric team, and they took her to theatre and they delivered the twins. I was assigned to one twin and another med student was assigned to the second twin, and we had to, I don't know why I'm smiling, because it was actually like a very high pressured, it was actually a very high pressured environment. Like when we were in theatre, I had to document. I was documenting with the age of the baby, so from the time they delivered the baby and put them on the, I don't know what's the name of that machine now that you put the baby on, the timer starts going, and that indicates the age of the baby. So I would write down the age of the baby. So at 1 minute they did this, at 2 minutes they intubated the baby, at 3 minutes they gave this medication, or at 4 minutes they gave this injection. So I was writing that down because the midwives needed that to be able to document. Documentation is so important, literally so important. So I think the time from when the woman came into when she delivered her twins, it was about 3 hours, and we were with her every step of the way. Like I did not sit, I did not even have lunch that day. But it was amazing because I'm glad the twins were fine and the mother was fine. So it was great. It was a great experience. I loved it. By the time week 2 came around, I was more prepared. So because I said that my experience in week 1 with the teaching gave me like a kick in the butt. So I had to make sure that I went through my notes over the weekend. So I was a bit more prepared when I went back to hospital. When I was in clinic, so I was in the gynaecology clinic, I asked if I could clerk patients. So if I could take a full history from the patients. So I called while the patients were waiting for the doctor, because the doctors, usually the clinics run over. So I just went and got the patient. I went to another room that was empty and I took a full history from this patient, and then just formulated a diagnosis, like differential diagnosis in my mind, and just to make sure that I understood what was going on, and tried to think of what investigations I would do or how I would manage the patient, which really helped my learning, and I thought that was good. I spent most of the week, the second week, on the labor ward, so I saw loads and loads of different vaginal deliveries, like loads of vaginal deliveries, but there was actually a PA that was working in obs and gynae. I finally met the PA because I'd been hearing about her, but I didn't know, I'd never met her. So I finally met her in the second week, and she's actually really nice. I asked her questions about how she's finding it. She said that she worked in GP for her first year, then she worked in hematology, then she's now working in obstetrics and gynecology. And she's been working there only for about a month now, but she's been getting the hang of things. They let her assist in surgeries as well, like in the Cesarean sections and in the main theatre and the main surgeries where they do gynecological surgeries. They let her assist as well, which I thought was really cool. Because I was on the labour ward for most of that week, I was also in maternity triage as well, which is A&E for pregnant women, really. So you had a lot of pregnant women there who were over 15 weeks, so they would come to maternity triage. It was open 24 hours a day, 7 days a week, so it kind of like A&E but for pregnant women. And you had pregnant women coming in with abdominal pain, they're coming in with abnormal vaginal discharge, and they had bleeding and loads of symptoms like that, and they would come in. The midwife would see them. There's usually a midwife there and HCA, they would see them, but then the midwife thinks that a pregnant woman needs to be reviewed by a doctor. She would bleep the doctor, and the doctor would come and examine the patient and review the patient. They could carry out an examination, maybe a speculum exam, and some tests to see if the woman is first. So for example, if the woman came in with abdominal pain, there's a test that you can do to see if the woman is going into labor, and it's like a pregnancy test. So in a pregnancy test indicates that it comes off negative with 1 line and positive with 2 lines, so you can check that. Some of the other conditions I saw that second week were it's what you call a PROM, which is a premature rupture of membranes. So when we say that the woman's water breaks, is that the abbreviation for that is SRUM, which is spontaneous rupture of membranes. And usually if it is a spontaneous rupture of membranes, the woman should go into labor within 24 hours. If she doesn't go into labor within 24 hours, then it's a PROM, so a premature rupture of membrane. So they would usually manage it as a PROM, and then see what they can do to progress for the labor to progress. Also, another condition I saw that week was hyperemesis when I was on the antenatal ward, and this was the ward where you had women who weren't technically in labor but who would come in for one reason or the other. Things like hyperemesis, so when they're vomiting a lot during pregnancy, and they would come in there and they would treat them with different antiemetics just to make sure that they can control the vomiting. Some women don't have as much, nausea and vomiting, but some women have it really bad. And I saw an emergency cesarean section on week 2. Everything was going fine, the woman's labor was progressing fine, but then on the CTG, which is the I can't remember the full name now, but it's what they use to monitor the heart rate of the baby against the contractions of the woman. Contractions of the mother. So the heart rate of the baby should be between 110 and 160. If it goes below 100 or like if it goes below 100 and stays there for at least 2 minutes or so, that is classed as a deceleration and it's an emergency. So that means the baby is in distress, and they have to get the baby out immediately, and the only way they can get the baby out is via emergency cesarean section. So I saw one of those, emergency cesarean section, where they had to get the woman straight into theatre. They put her under general anesthetic, and then they got the baby out like really quickly. The pediatric team was on standby as well, just to make sure the baby was fine and that nothing would happen to the baby. The baby was fine, the mother was fine, which was good. Because there were so many people in theatre, I had to wait outside for a bit, and then I went in when everything had calmed down. But it was really cool to see how quickly like everything was being done, because in elective cesarean sections, which are cesarean sections which are planned, they take their time to do everything, but then in emergency conditions, you see how quickly they can do all of these things, and it's just amazing how they do it. So my last week I was in the early pregnancy unit with the PA, so I spent a whole morning with her, which was great. She was in the early pregnancy unit. I think she was the only junior person there. There were consultants there as well. It was really sad. I think in week 3 I saw like the sad aspect to obstetrics and gynecology. So in the early pregnancy unit is women whose pregnancies are less than 15 weeks. So if they're over 15 weeks, they go to maternity triage, and if it's less than 15 weeks, they go to EPU. You had a lot of women who came in there, and then they did a transvaginal scan. And so, for example, if they had seen bleeding and abdominal pain, they would do a transvaginal scan to see if they'd had a miscarriage. And it was really sad that they would come in there, and then depending on what the scan showed, the sonographer would have to tell them that they've had a miscarriage. And I didn't realize how common miscarriages are. They're actually 1 in 4, like 1 in 4 women would actually experience, the statistics show that 1 in 4 women actually experience a miscarriage in their lifetime, which was a shocking statistic for me. Like, I didn't know that miscarriages were that common, but apparently that's how common they are. I also sat in with the PA as well. She saw patients who needed to be reviewed, and so, for example, if they'd had a miscarriage and they'd retained some products of conception, they could give the medication to cause the uterus to contract, so they can get all of the products of conception outside of the uterus. But also women who had abortion, or who were thinking about having abortions, or who have had abortions and had retained products of conception, they could manage the pregnancies appropriately. So if they would see if they wanted medical management, or if they wanted surgical management as well, so the PA could either manage them medically, or they could refer them for surgery. I was also in the gum clinic. So I was in the gum is genitourinary medicine. I was in the gum clinic on one of the days in my last week, and the gum clinic is also known as a sexual health clinic. So you had a lot of patients who come in there if they're worried that they had a STI, so presenting complaints like abnormal vaginal discharge, or men who would come in with symptoms like urethral discharge, or if they had sores down below, or if they'd slept with someone, if they'd had sexual intercourse with someone who has an STI, or if they were a contact. So if someone had come in there and had been tested for an STI and they were a contact with this person for like the last 3 months, they would call them in to come in and get checked. They will do blood tests and tests for syphilis and HIV, and then check for chlamydia, gonorrhea, infections like bacterial vaginosis and thrush. And it was really cool to see how the nurses, when they would take the samples, they could put it on the slide, stain them, and look at the samples under the microscope to see if it was bacterial vaginosis or thrush, and then they could give the medication there and then. The gum clinic is a very interesting place because it's a breeding ground for a lot of drama in terms of between partners and stuff. And yeah, so if you're going to the gum clinic for any sort of placement, just know that you might see some drama. And then one of my favorite moments of the whole placement was when me and another PA student, we helped deliver when a baby. When the baby came out, they found that it was a boy. The mother was crying, the grandmother was crying, I started crying. I was like, why am I crying? It's not even my baby. Yeah, just the joy in the mother's face and the dad's face and the grandmother's face, and how everyone was just like, oh my gosh, congratulations. Like, it just made me think, I can't wait to have a baby as well. I mean, I can wait, but like, it just makes me think what it would be like when I have my own baby. Like, it's just so nice. And yeah, I just loved it. One other thing that I would say that's really cool about obstetrics and gynecology is that is the main like surgical aspect of it. So a lot of the people that work in obs and gynae, when they become consultants, like, they are surgeons because they carry out surgery, be it C-sections or gynecological surgery, so removal of fibroids, things like hysterectomies, taking out the uterus, or hysterectomies or salpingo oophorectomies, where they remove everything. They remove the uterus, they remove the tubes, they remove the ovaries, removing like cysts as well, ovarian cysts. Or for example, if a woman had an ectopic pregnancy, they would do a surgery to remove the pregnancy. Some of my colleagues, my PA student colleagues, were actually in theatre with the doctors, and they actually let them assist in those surgeries, which I thought was really cool. So that was really great because the people actually, the so pro PAs, the consultants, they were so pro PAs, and they let us do loads of things, which I thought was really cool. I learned so much from this placement. I'm so grateful for the exposure, all the different aspects of obs and gynae that I was able to experience. It was such a great learning experience for me, and again, I still have to go back and go over all the conditions that I encountered over the last 3 weeks. It's certainly a very interesting specialty. I really loved it. It would be really good for people who are interested in the surgical aspect of things as well. So for example, if you want to do both sides, so there's loads of things that you can do. You don't really get bored because you're doing loads of different things. So from sitting in the clinics to doing surgeries or helping out or assisting in surgeries and doing loads of other things, I think it's a really cool specialty in that respect. My one advice, like I said, would be to make sure that you prep before you go. Yeah, because it has a lot of things. There's a lot of abbreviations that they use, and there's just so much, so you need to prep before you go in. But yeah, that was my experience with obstetrics and gynecology, guys. I hope that this is giving you some insight into how my last 3 weeks have been. My next placement is mental health. I don't know how I feel about that, but I hope that is going to be great. Again, I'm going to spend the next 3 weeks, jotting down things that I've learned and my experience, and I'll share with you guys at the end of my placement. But yeah, let me know down below if you have any more questions about my placement, and have a lovely day, and God bless. Bye.
Also in the name of Jesus, oh yeah, I am free, I am not free. Praise the Lord, it is a wonderful something. I'm just saying thank you. I am free, I am not free. No, praise the Lord.